Welcome to the Deep Dive, where we sift through research, articles, and notes to bring you the most potent nuggets of knowledge. Today, we're plunging into a topic that honestly touches almost everyone's life at some point: leaving the hospital. You know, that feeling, the immense relief of finally heading home, but maybe sometimes there's that little whisper of anxiety about what comes next. Have you ever wondered what really goes into getting a patient safely from their hospital bed back to their home or the next care setting? It's definitely not as simple as just walking out the door.
Okay, let's unpack this a bit.
Yeah.
Because it's not just about getting better in the hospital, it's, making sure that recovery continues smoothly after you leave.
Exactly.
If that crucial transition isn't handled well, it can lead right back to square one or maybe even worse. The problem of hospital readmissions, especially the ones that are preventable, it's a massive global concern. It's a key indicator of how well our healthcare systems are doing and, most importantly, the quality of patient care. It really is. It's a complex puzzle, but thankfully, there are dedicated experts working to solve it, often quite systematically. And what's truly fascinating here, I think, is how a group of experts in Hong Kong approached this very challenge.
Yeah.
They didn't just speculate or, guess. They used a highly structured, almost democratic process to build a consensus on what an effective hospital discharge system should actually look like.
Okay.
So our mission in this deep dive is really to explore their framework, the why, the how, and the what of creating it, and then see what powerful insights it offers for improving patient transitions, not just in Hong Kong, but potentially everywhere.
Right.
We're drawing primarily from a really interesting research article by Yam and colleagues, published back in BMC Health Services Research in 2012. It details their unique method for developing and, importantly, pre-testing this framework.
Okay, so let's kick off with the why then. Why is getting discharge planning right such a big deal?
Well, just consider the sheer scale of the problem. Hospital readmission rates have increasingly become this critical barometer of healthcare performance and, patient safety. For example, one study found that nearly 40% of hospital readmissions in Hong Kong were actually preventable.
40%. That's huge.
Think about that, almost half. That statistic alone highlights a huge opportunity, not just to improve individual patient outcomes, but also to alleviate, immense pressure on our already strained hospitals.
Absolutely.
It really underscores the profound importance of a seamless handoff, not just for the patient, but for the entire healthcare ecosystem.
Precisely. And if we connect this to the bigger picture, a robust, well-defined discharge planning system isn't just about making things more efficient, though that's part of it. It's fundamentally about improving the continuity of care, actively reducing those avoidable readmissions we just mentioned, and providing that holistic medical, social, and rehabilitation support.
Right, the whole picture. Yeah, because today's patients often present with increasingly complex needs. Think about managing multiple chronic conditions or requiring extensive rehab. This really demands a multidisciplinary team approach.
Definitely.
So systems simply must be smart enough to recognize these varying patient needs and adapt. They need to ensure both patients and providers feel secure and clear about what comes next.
Yeah, predictability.
Predictability and security, exactly. And while other countries, Australia, the US, the UK, they've launched their own guidelines, there are variations because of different healthcare structures and cultural contexts. But in Hong Kong, before this initiative, discharge planning was often quite fragmented. It lacked consistent coordination. That made a structured approach even more critical there.
Okay, so now that we understand the critical why, the sheer human and systemic cost of poor discharge planning, let's dive into the how. You mentioned it wasn't just built by a single committee. These experts used a remarkable technique called the Delphi method. Can you explain what that is and, why it's such a powerful tool for getting agreement on something as complex as patient care?
That's a great question because the how is genuinely innovative here. The Delphi method is basically a structured communication technique. It was originally developed, I believe, by the RAND Corporation for things like forecasting and policy formation. It brings together a diverse group of experts to reach a consensus on a complex issue without ever needing to meet face-to-face in a traditional debate setting.
Oh, interesting. So no big arguments in a room.
Exactly. And this raises that important question. How do you get so many experts to agree? Well, its core characteristics are key. First, there's anonymity. Opinions aren't swayed by dominant personalities or, say, someone's job title. Then there's iteration. It allows for multiple rounds of feedback and refinement. People can change their minds based on the group's thinking. There's also controlled feedback, Everyone sees the group's aggregated responses after each round, but anonymously.
Ah, so you see where the group is leaning.
Precisely. And finally, there's a statistical group response to clearly measure where the consensus actually lies. This systematic, anonymous approach is incredibly valuable for reaching agreement on intricate issues. That's why it's used in fields from public health policy to establishing international consensus on medical procedures.
So it sort of takes the best of group wisdom, but without the pitfalls of like groupthink or just a few loud voices dominating everything.
That's a really good way to put it.
That makes so much sense. And in this particular study, you said it was a part of a larger three-staged process.
Exactly right. Stage 1 involved developing the initial framework. They looked at international best practices, but also did extensive local input interviews with patients, focus groups with frontline healthcare workers, even individual interviews with hospital executives.
So really grounding it.
Definitely. Then Stage 2, which is the heart of the research we're focusing on today, applied that Delphi method to pre-test this initial framework among a panel of experts. They checked its clarity, its validity, and crucially, its applicability.
Applicability, can it actually work?
Yes. And finally, Stage 3, which was actually underway when the paper was written, involved piloting the refined framework in a hospital setting to evaluate its real-world feasibility and impact.
Got it. And who are these experts putting their heads together in Stage 2?
Well, the study gathered 24 highly experienced healthcare professionals. We're talking doctors, nurses, physiotherapists, occupational therapists, and medical social workers. A real mix.
A proper team.
Absolutely. And each had at least 5 years of relevant working experience, ensuring they brought deep, practical, frontline knowledge to the table.
That multidisciplinary approach seems absolutely vital, right? Because discharge planning isn't just about one thing. It spans medical, physical, psychological, social support.
You need all those perspectives for a truly comprehensive and ultimately effective plan.
Okay, so they had this initial framework. 36 statements covering everything from screening to follow-up under 5 big themes. And each expert rated these statements independently using what's called a 5-point Likert scale.
That's right. Basically, strongly disagree to strongly agree.
Right. Judging not just if the statement was relevant, but if it was clear, valid, and crucially, if it could actually work in a real hospital. That applicability point again. And for a statement to make the cut, it needed, what, 75% or more of participants scoring high, a 4 or 5 on all 3 aspects: clarity, validity, applicability.
Correct. If it didn't meet that threshold, it went back to the drawing board for revision.
Okay. So what happened in that first round? Did everything sail through?
Well, this is where the real-world constraints really hit home, and where the Delphi method's iterative nature proved its worth. In round 1, while many statements did achieve consensus on clarity and validity, a significant number, actually 11 out of the 36, fell short, primarily due to concerns about applicability.
11. Wow. What were the main sticking points?
The experts, with their daily experience on the wards, highlighted very practical roadblocks. Things like a severe lack of manpower, sometimes insufficient skills for certain tasks, and simply not enough time.
Time. Always time.
Always time.
Right.
Especially during weekends and holidays, trying to carry out assessments or initiate care plans within that ambitious 24-hour admission window. It was tough.
I can imagine.
And there were also consistent issues raised about the timeliness and availability of arranging specialized transportation or getting necessary equipment for patients needing it upon discharge.
Right. The practical nuts and bolts.
Exactly. It vividly underscores that a perfect plan on paper doesn't always translate when you're facing staff shortages or trying to coordinate complex logistics on a Saturday afternoon. It's a powerful insight into the value of involving those who actually have to implement the plans.
That's such a crucial point, connecting the theory with the reality on the ground. So seeing those real-world constraints surface in round 1, how did the experts actually adapt the framework for round 2? Yeah. What changes did they make to bridge that gap between the ideal and the achievable?
That's precisely what happened next.
Yeah.
In response to these really honest frontline concerns, they made some vital revisions. They rephrased several statements to use more flexible language. For instance, performed was changed to initiated.
Okay. Subtle but important.
Very important. Ensured became facilitated. And something like booked at least 24 hours in advance was modified to the more pragmatic, timely transport arrangement.
So acknowledging the variability.
Exactly. This isn't just playing with words. It reflects a shift from rigid directives to acknowledging the practicalities of a busy, often unpredictable hospital environment. They also added a crucial new statement based on the feedback. The role and responsibility of different healthcare professionals for the different tasks in the discharge planning process should be clarified.
Ah, emphasizing clear teamwork. That sounds key.
Absolutely. Participants also stress the need for effective and accessible IT systems for communication across disciplines, sharing information seamlessly while, of course, making sure patient privacy was safeguarded.
Makes sense.
And one more thing, to better reflect the true scope of early patient engagement, they renamed the first theme. It went from just initial screening to initial screening and assessment.
I see. So broadening it out slightly.
It shows it's not just a quick check, but a more involved process right from the start.
It's fascinating how those real-world challenges in round one really pushed the experts to refine their thinking. And the outcome wasn't just a more flexible framework, but one that hopefully reflected the realities on the ground, making it far more practical.
That was the goal. And it led to consensus on all statements in round two.
Great. So this brings us to the finalized themes, which now embody that hard-won consensus. Let's explore what this refined framework ultimately looks like. First up, theme one. Initial screening and assessment.
Right. What's insightful here isn't just identifying risk early, but the depth of assessment that the experts agreed was needed right at the beginning.
Okay.
It's about that early risk screening, ideally within 24 hours of admission, to quickly differentiate between patients with fairly simple discharge needs and those who will likely require a more complex, coordinated plan. They initially considered a specific tool called HARPIC, the Hospital Admissions Risk Reduction Program for the elderly.
Right, HARPIC.
But critically, the expert panel understood that just one tool or one score isn't enough for true patient safety, especially with complex needs.
So they added more?
They wisely augmented it. They added 7 additional assessment areas to consider alongside or instead of HARP, things like a patient's social support network, any recent changes in their activities of daily living, ADL.
ADLs being basic self-care, like bathing, dressing.
Exactly. Also their functional ambulatory category, how well they can walk, any history of fall risk, their mental state, and even medication compliance.
Wow, that's comprehensive.
It really is. It's a testament to the experts' recognition that a single metric is rarely enough. It pushes for a truly holistic view right from the start.
Okay, that makes sense. What's next? Theme 2, discharge planning process.
So moving on to theme 2, this focuses on the ongoing clinical and functional assessments and, importantly, the development of that tailored care plan we talked about. The framework specifies 4 main assessment dimensions to cover: medical health, physical function, psychological well-being, and social functioning.
The whole person again.
Absolutely. And reinforcing that emphasis on timeliness we saw earlier, the consensus was that the care plan itself should be initiated within 24 hours of admission. It also outlines 3 distinct categories of discharge plans to allow flexibility: generic plans for simple, straightforward cases, disease-based plans, which use specific protocols for common conditions like heart failure or COPD, and then truly tailored plans for those complex cases identified earlier.
Right, matching the plan to the need.
Precisely. This flexibility ensures care is appropriate and efficient for diverse patient needs.
Okay, so once that tailored plan is meticulously developed, the real challenge becomes making sure it's executed seamlessly, right? This brings us to theme 3, coordination of discharge. As the name suggests, this is all about preventing any gaps as the patient transitions out. What's one of the most vital elements here for you in stopping things falling through the cracks?
For me, a really critical piece is the emphasis on clear accountability and communication. This theme calls for a designated person, whether it's a doctor, nurse, or maybe an allied health professional like a social worker, to be clearly responsible for overseeing the entire discharge planning process for that patient.
One-point person.
One-point person. And crucially, it also clarifies the roles and responsibilities of every member of the multidisciplinary team involved. No more wondering who's supposed to do what.
That clarity seems essential.
It is, and for high-risk patients, it mandates case conferences to ensure everyone is absolutely on the same page. Beyond that, it's about the practicalities. Assessing the suitability of the discharge destination is home safe, are modifications needed, ensuring prompt social support referrals if required, and implementing formal mechanisms for information transfer to community providers. Think a proper, detailed discharge summary, not just, informal chats or hurried notes.
Yeah, that formal handover is key.
Hugely. And, critically, the framework says the prompt provision of essential community equipment, maybe a walker or oxygen, should be facilitated. Plus, appropriate education for both patients and their carers on how to use any equipment and manage their medications safely. These details are often what make or break a smooth transition home.
Absolutely. Those formal mechanisms for information transfer really stand out, ensuring no critical details get lost in translation. Following that, theme 4 is implementation of discharge. This theme seems focused squarely on making sure the patient is truly ready and that all the necessary post-discharge services are lined up precisely. What are some of the standout practical elements here?
Two elements really stand out for me in Theme 4. First, it's the deep engagement with patients and their carers, providing clear information not just on their illness, but vitally on danger signals they should watch out for once they get home. What warrants a call to the doctor, or even a trip back to the ER.
Empowering.
Exactly. Second, it's the provision of a specifically designed patient discharge summary that's actually given to the patient or their carer upon leaving. This should include essential information like their clinical diagnosis, any follow-up appointments, clear instructions for medication, contact info for support services.
Everything in one place.
Yes. And for complex cases, clear contact information for who to call with concerns after discharge is also essential. The framework also re-emphasizes that timely transport arrangement for discharged patients, and it suggests using a patient checklist to empower them, making sure they understand their plan before they actually walk out the hospital door. It's about giving patients the knowledge and resources to continue their recovery confidently.
That checklist sounds like a really practical tool. And finally, theme 5. Post-discharge follow-up. This really closes the loop, doesn't it? Ensuring continuity of care extends beyond the hospital doors. What does this theme emphasize for ongoing support?
Yeah. Theme 5 ensures that the baton isn't dropped once the patient leaves the acute setting. It specifies that if a patient with complex needs is transferred, say, from an acute hospital to a rehabilitation facility, there must be clear verbal or written communication between the healthcare professionals involved at both ends.
Connecting the dots.
Connecting the dots.
Yeah.
Similarly, for patients referred to specific disease management programs or special discharge support services in the community, structured person-to-person or written information transfer between the hospital team and the community providers is crucial. It's all about maintaining that thread of care, ensuring no patient is left feeling adrift or navigating their ongoing recovery alone.
So, bringing it all together.
Ultimately, this framework provides an incredibly valuable reference point, not just an academic theory. It's for policymakers, hospital managers. It's a practical blueprint for tangibly improving the quality of care and, crucially, for reducing those unnecessary, costly, and often distressing hospital readmissions. This is especially important in really busy acute care settings, like the Hong Kong hospitals where this was developed, which often have rapid patient turnover. The study successfully reaffirms the importance of having a structured, systematic, and coordinated system, one built from real-world expert consensus.
So, what does this all mean for you, the listener? Well, it means when you, or maybe a loved one, are preparing to leave the hospital, there's a recognized, expert-backed system that should ideally be in place to ensure a smooth, safe transition. Knowing these components from that early assessment and having a designated coordinator to understanding your discharge summary and follow-up plan, it really helps you understand what to expect and maybe even what crucial questions to ask. You can truly be an active participant in ensuring a well-coordinated discharge, moving from simply being discharged to actively progressing in your recovery journey. Yeah, this deep dive truly illustrates the power of bringing diverse expert perspectives together, doesn't it? Even if, or maybe especially because, they uncover uncomfortable truths about, applicability and resources along the way. The journey of this framework, from those initial ideals to a consensus-based practical solution, really highlights how integrating frontline experience into policy development can transform theoretical concepts into genuinely workable, impactful solutions for patients and for the healthcare system itself.
It does. And the study highlights that while a robust framework like this is essential, its true power really lies in its ongoing applicability and evaluation within these dynamic healthcare environments. Things change. So it leaves us with perhaps a provocative thought to ponder. Beyond simply preventing readmissions, which is vital, how can we leverage frameworks like this to truly integrate hospital care with long-term community wellness? How do we make that journey home not just safe, but a confident, supported step towards sustained health and continuous well-being for the long run?
That's a powerful thought to ponder as we continue to evolve our understanding of patient care, moving beyond just fixing the acute problem. We encourage you to reflect on your own experiences with hospital discharge, or maybe those of your loved ones, and consider how these kinds of structured, coordinated approaches could make a meaningful difference. Thank you for joining us on this deep dive. We'll see you next time.